This meeting is now being recorded.
As you're recording them on the press report. If star 6 will mute all the chatter that we're hearing right now. To talk to us again, star 6 as well. I will start with some introductions in the room. Not everyone is here, but I'll start to my right. That's your.
Hi guys, this is Angie Fellers-Lanier, the nurse consultant.
This is Chris McCracken, program coordinator.
Marina Milzer, data manager.
And Emily has left the room for a few minutes.
Left the building.
We're going to talk about the CDC core indicators this morning. Some of you have heard us talk about core indicators for many years. Some agencies have requested refreshers, and some of you are new to the WWC Clinical Services Program. Chris and I and Flora, who today, Flora's last day, want to thank you for all your hard work on the Q1 progress reports. We have been diligently reviewing them, and we have seen some themes on the progress reports, especially with how agencies were answering the questions about performance indicators. So we're going to spend a little time this morning reviewing those indicators, provide some examples of what we saw on the progress report. So we are not identifying agencies, but you might see your answer if the PowerPoint does in fact come up. We also have some agencies that are going to share their experiences with always achieving and meeting their CDC core indicators. So I think we apologize for not having the presentation coming up, but I will turn the agenda over to Chris for the moment, and you're gonna hear us just talking this morning.
Sorry about that.
I'm gonna go download it onto the computer.
Okay.
But even if you clear it.
Sorry,
Sorry that you hear all of us chatting. We're just trying to figure out how to
figure it out. We're no longer sharing
up.
I'll
go do that.
Okay. So we wanted to start with a quick review of the core indicators, and if you are signed on and receiving the blog, Women's Wellness Connection Forum, you will have received yesterday what we were calling a quick review. So I hope you had a chance to look at that. What we're talking about is really the 6 core indicators that we call the CDC core indicators, because they are we are required to meet these performance measures by the CDC. So they are as follows. Rarely or never screened for cervical cancer. Women 50 and older receiving mammograms. Abnormal breast cases with complete follow-up. And then those cases, the timeliness of care for those abnormal breast cases. Abnormal cervical cases with complete follow-up, and timeliness of care for abnormal cervical cases. So we have a couple things, a couple ways for you to keep track of your indicators. And the primary way is for in eCaST, there's a core indicator report. So you have access to that whenever you need it. Angie, did you have some things you wanted to talk about with these indicators?
Not on this. I think as we move along, yeah.
Okay, great. So does anyone have any questions right now about the core indicators? About what they are, how we measure them, anything.
*6 for questions.
Yep. Okay. That is fine. So, we changed a little bit our process for progress reports. You will know that by now. So we asked you to, as Ivy said, to look at your progress report, your core indicator report in eCaST, and let us know and whether you're meeting each of those 6 indicators that I just mentioned. I wanted to bring up a couple things. Number one, we noticed that the report that you printed off of eCaST didn't match the same order that we had you answer questions in the SurveyMonkey. So I think breast and cervical were flipped from each other. So I know most of you noticed that, and you did a good job with that. Can you answer that and say no? So let's see, what else? The date parameters, most of you got the date parameters correct. We were using September 1st, 2004 through August 31st, 2015.
And I had a lot of questions about why do we go back in time? Why are we running reports that started on September 1st, 2014 instead of currently?
Yes, so this is Kristen Lara. I came into the room late. So mostly Chris McCracken and I talked through what date parameters to use. Core indicators really look at very specific cases, and so we wanted to make sure you had enough data to be able to really, truly reflect what performance looks like in the past. Mm-hmm. In addition to that, recent data is very hard to look at because cases that are abnormal could take up to 60 days to close, and that's totally fine. Mm-hmm. And so those are a couple of reasons why we look fairly far back in the past and why we have to look at a large amount of data in order to make sure that we're really truly seeing what your clinical performance looks like. The downside of that, of course, of not being able to see just for 1 month what happened is that it's harder to see trends over time. Mm-hmm. And it might feel a little less actionable in the sense that if you failed an indicator in the past, really what you have to do moving forward is change those processes to make sure you're setting yourself up for success moving forward. Mm-hmm. And it might take time for your reports to reflect those sorts of changes. But I believe for the following progress reports, you will also see a complete 1-year period will be assessed based on. And one last note, as most of you know, is that through your data cleanup projects we complete every 6 months. But for that, we do look pretty far back in the past. The CDC looks back upwards of 18 months when they review and assess our clinical performance as a state.
Hi, sorry, Kristen. Hey, can everyone start 6 phones, please?
All guests have been muted. You can unmute your line by pressing *6.
Okay, thanks.
Hi, everybody. This is Kristen again. We just muted everybody at *6 to unmute yourself if you have a question. Feel free to do that. We were just getting some interference. But yeah, so the core indicators from the CDC go back 18 months typically. And so we want you to be used to us asking about some fairly old data, as that's what the CDC asks us to look at and grades us on typically. But very good question when you guys had that for Ivy and Chris.
Okay, thank you. Hey, look at us. We're seeing a presentation, so I hope you guys are too. Gosh, that was a lot of work. So basically the main thing we wanted to talk about today was this question that we asked on the progress report that read, for indicators not met, please provide an explanation and an action plan for improving future performance. So, and we, as Ivy said, as we were reading, we realized we kind of wanted to offer you some assistance in answering these kinds of questions and share with you some answers that we felt were really good and some suggestions. So, here was one answer I saw that was in response to the agency not meeting the screening mammogram indicators of women over 50. And they said, in an attempt to better meet these core indicators, we will continue enhancing knowledge of our clinic to other practices in the area who do see more of an older demographic of patients. That this agency had previously in that paragraph talked about the young population coming into their clinic. And that, what we have here is a specific plan to improve the indicator. Another action plan might include using shared decision-making to determine if a patient would like to be referred for screening mammography. Give those patients 40 to 49 with average risk for breast cancer a choice, whether to screen or not.
So once you've done the targeted screening counseling, you may have some clients who do want to put off screening mammography for a year or a few years, and that would be okay. And that's just making sure that the providers are having that discussion and giving the patient a choice.
Okay.
If you guys have questions, we did have to mute you also. It's *6 to unmute. We'll have discussion in a little bit. We were just going to give some examples to start.
Yeah. Ivy, why don't you do this one?
So another agency that we saw, this particular agency is new. It's XYZ. It's a new agency. Has not focused on rarely or never screened at initial Pap test. This agency told us they will target women meeting this criteria in reach activities moving forward. The agency will incorporate this filter to prioritize these women in a list of eligible women for screening. This is an agency that has an active EHR as well. An example of how you could improve this indicator is reviewing the ASCCP PAP HPV screening guidelines with all of your providers providing WWC clinical services at your agency to ensure that the recommended intervals are being followed. Angie, do you have anything to add to that slide?
No, I think that was good.
Another example, another new agency, LMN, is not meeting breast abnormal screening with follow-up. This agency will implement efforts to obtain timely results from providers, not piranhas, as well as to respond to any abnormal results that have significantly improved follow-up. This agency has a cancer screening program manager who meets with their clinics on a weekly basis and will follow up on all open referrals. Agencies that have multiple clinics are normally FQHCs or a larger hospital system as well, so their structure operates a little bit differently.
Mm-hmm. So anyone who was at one of the 2 road shows this October knows that we awarded 5 agencies the regional Shirley House Hewitt Quality Awards for their performance, their outstanding performance in these indicators, and more importantly for this particular call is they've showed improvement in a number of these indicators as well. And we also had 2 agencies that did so well. We created a special honorable mention category. So what we have asked some of those folks to share with us maybe some of their improvement plans, or just maybe even some of their processes on how they do it. How do you do it?
How much do they rock?
Yeah.
How do they create? What's in their awesome sauce?
Mhm. Exactly. Do we want to call on anyone?
Sunrise, if you're out there, Sunrise has won our overall state award last fiscal year, and they're a regional award winner this year. And they're going to share a little bit about their program and how they've achieved their level of success. So if you are out there, Sunrise, *6 to unmute yourself. We'll all hear you.
Claire's here.
Hi,
I'm here.
Claire. Hi,
And this
lady.
is Virginia, too.
The whole
Thanks
team.
for being here, too.
I knew you were.
Hello.
Hi.
So we could go through each one, right, Claire?
Yeah.
We could break through each of the core indicators and kind of talk a little bit in each one.
Okay.
Thank you. Here, we'll go back to the list for everybody so they can follow along.
Yeah, if you want to go through each of the list, and then we could talk a little bit in each one.
So, rarely or never screen for cervical cancer.
So for that, that was one where we, as a clinic, identified a few years ago that we were not doing well.
Uh-huh.
So we talked to our IT department and asked them to create a report using our EMR of women who were due for PAPs.
We're basically 50 and over.
Yeah, and or 40 and over, so that
Yeah,
met
40
the
and over.
CDC guidelines.
Exactly.
And then Virginia and I just started calling those women and getting them in, and we started.
We had PAP clinics. That's
Yeah.
what we did, actually.
Yeah, so in the PAP clinic is where we just reserved like an afternoon where one provider, all they were doing is PAPs. So we would fill their afternoon or morning with the women that we were contacting and get in as many as we could. So we could get in, 15 women in one afternoon.
But we were also linking them with us, so they would see us first and then see the provider right after us and have their PAPs done.
Mm-hmm. So they're enrolled in WWC.
Oh, yeah.
So that's, I think, a great example of one of the evidence-based interventions to increase cancer screening is patient reminders. And so often going into that is using your EHR or other thing to find out who needs that reminder, what patients should I target for a reminder. So I think that's a great example, and I'm sure you probably did some education with them as well when you were contacting them to get them scheduled about why it's important, which would be an example of one-on-one education, which is also evidence-based.
Yeah. So moving forward, we've moved away from that, but moving forward, we're now moving to a more upgraded system called Eye to Eye. Right, Samantha?
Right.
So you could talk more on that.
The Eye2Eye brings out reports of schedules for the patients for the day, and the MAs go ahead and pre-screen appointments, and they'll go ahead and identify which patient is needing a PAP or a colonoscopy or other preventative measures, so that they're pre-screened, and the MA can then discuss with the provider to set up the room for specific needs. So.
And then they'll still see us. But that's still to come. That's a work in progress that we're going to hopefully be working on here real soon in the near future.
Right. Do you want to move on to mammograms?
Sure.
I think that one, I guess, is just talking with providers. We've
been following the USPSTF guidelines at our clinic. So providers typically are referring women over 50 for screenings, and then if they're between 40 and 50, only if they have family history or after they've had that conversation with them about the risks and benefits of mammography. So I think that one just is came a little more naturally, just based upon what our providers are doing and who they're referring for mammography. I don't know if there's anything else to add.
Yeah, I mean, that one, again, we just felt like they just went hand in hand together, so that just naturally kind of went together. And again, I mean, we're kind of out there. We go to our providers' meetings. I mean, we kind of put ourselves out there. We're kind of always hammering at them, notifying, kind of battling with them, letting them know we're here. We have this program. Please, please, please refer all of your women to us. We want to get it done. So we're kind of just always in their face. So that's another thing that we use too.
I like it.
So what about complete follow-up for abnormal breast cases?
So that one we talked about, both of us have really good relationships with the nurse practitioners at the breast centers. So the hospitals or the subcontracting hospitals that we work with, each of them is staffed with a nurse practitioner that just handles breast health. And we have their direct number. They have our direct number. They contact us when there's follow-up that's needed, so that we are aware right away. Our clinic also has access to the hospital's EMR, so we can get in right away and get that report and print it and put it into our EMR. So there's not that time lag of trying to get records sent over and know what the results are. We have immediate access. So that helps. And then so the patient's getting the message from both our clinic and the subcontracting hospital that they're needing follow-up, and we're all working together to get that scheduled and addressing any barriers. And our policy at the clinic is similar to the WWC policy, that we make 3 attempts to contact by phone, and then we'll send a certified letter. But honestly, in the 3 years I've worked here, I've probably sent maybe 1 or 2 certified letters. It's very rare that we even get to that point.
Yep. And the hospital's doing the same thing. So it's just, even before here, we're a little bit different, still Banner, but most of the time the client knows even before they leave for that screening mammo if they're going to have follow-up. So they know when they're anticipating that call and they're waiting to be scheduled, so they know. And we're working at date order, so we're pulling results 1 to 2 times a week. So we're constantly following up on that.
Great.
So it seems like that maybe addressed timeliness
as
well. It was complete and also timeliness.
Yeah.
No, that's fine. I think that they go hand in hand a lot of times.
Yeah.
Was there anything you needed to add about timeliness? But I think you addressed it with
No, we kind of grouped those 2 together.
Okay. Do you want to do the same for cervical?
Yeah. And I think the other thing I'll mention, because I don't know if it's true for every site, but Virginia and I both have direct phone numbers and then voicemails, because I think if the coordinators don't have that, or the navigators, I should say, then it can be hard for the patient to get a hold of us. So I think that's something that's really important if it's not happening other places. And that's true for breast or cervical. And then for the cervical piece, we do basically all the cervical care in-house. So we offer colposcopies here for our patients. So that one's just, again, pretty easy because we can be in contact with their provider, get them scheduled through, we have access to the scheduling. We can just get them scheduled ourselves and schedule the procedure room. So I don't know, that one, just because we do basically the whole continuum of care here, it's really easy to navigate that one.
Okay, great. Does anyone have questions for Sunrise about any of those things they talked about?
Yeah.
I have a question. This is Angie, the nurse consultant. Your EMR is not the same as the hospital, is that correct? It's just that the hospital is giving you access to their EMR.
Correct.
That's right.
Okay, that's great.
Okay. Well, you can ask them again later also, because they're going to stay on the call.
Star 6 unmute if you have a question for Sunrise. Thank you for sharing. I feel like I got some helpful tips out of it.
Even though you're
I
not
want to say thank you to Sunrise, and I do have a question, if that's okay.
Yes. Who is this?
This is Shanna from St. Joseph again.
Okay. Hi.
Hi. So it sounds like the biggest piece of this was a lot of phone work and a lot of just reaching out to patients constantly. Is that what you guys feel is where you invested most of the time and resources into?
We do. I mean, we definitely do a lot of patient navigation. We do, if needed, if there's any abnormal, we definitely keep on top of that. But it's also just that partnership of working with personally over here in Greeley, we have it's a breast health nurse. Well, it's a nurse practitioner. They're always calling. If it's an abnormal, we're always following up to make sure that client's getting scheduled and getting the services they need. So.
But yeah, once they've done the initial enrollment, it's mostly phone work. We're not having the patient come in unnecessarily if it can be handled over the phone.
Yeah, I thought it was very interesting what you did with the PATS clinic and added that into your regular schedule and just had a specific clinic. Did you do that multiple times?
Yes.
Yeah.
For a while, we were doing it like once a month or twice a month when our numbers were really bad.
Okay.
You guys still do that?
We don't do PAP clinics anymore because we kind of
You've got your
we kind of
we got our numbers really up. Just as we come across them, we're just scheduling them as needed within within the clinic.
So once you got caught up, it became much easier to stay caught up, is what you're saying. And then, but to make that PAP clinic happen, that does sound like that's where you really invested a lot of phone time. And would you agree to that?
Yeah, definitely.
Okay. Wonderful. Thank you guys so much. That's very helpful.
Any other questions? Okay, I had 3 agencies email me yesterday and said they'd be willing to talk a little bit about their experience with the meeting the indicators or improving indicators. Is Peak Vista on the phone? Star 6?
This is Oshana.
Hi, Oshana.
Hi.
What can you tell us?
Sunrise, we do about the same thing as what they do. We had our IT department run a report of ladies who were needing PAPs or haven't had PAPs in a while. We do have access to our subcontractors' medical records as far as mammograms, and we have LabCorp access as far as PAPs. We do on-site COPOs here as well. Mm-hmm. We have information out in our enrollment services, so they look out for ladies that are due for their annual exams. And we do a lot of schedule scrubbing just to look and see if people qualify and moving them over to the providers that do the program. And we do WWC 4 days a week, Monday through Thursday, with 12 slots a day. So right now we're just having a problem capturing those CICP ladies. Mm-hmm. So we have a ton of the Medicaid or the case management ones, but the CICP ones are the ones that we're having the hardest time capturing. But we do clinic 4 days a week, so we at least have out of the 12 slots, probably is 5 or 6 that we fill.
Okay.
So it's just a whole bunch of communication, I guess. Like we all sit back here and the nurse does all the abnormal follow-ups, COPOs and breast. So
you guys all sit together, like, I know yeah, okay.
We all sit in the office, and me and Tammy have our own individual line, and then Cynthia has her own line as well.
Mm-hmm.
So, yeah.
What I like...
all that stuff.
Mm-hmm.
what I like is how these things are the same whether it's a clinical services client or a care coordination client. You would be doing the same kind of work. So that's, and I know both of your agencies are participating in both grants, so it's kind of nice to see that effort, and that was the idea of care coordination grant, is the same effort whether WWC is paying for their clinical services or Medicaid or a private insurance.
Because overall, it's all the same education. They all get educated the same. It's just a matter of what insurance you have or what payer source.
What grant
Which grant we're using, exactly.
Exactly.
And then we do a lot of calling. We do a lot of calling the no-shows or the people that cancel. We do a lot of that. And we do a lot. Me personally, I do a lot of scrubbing schedules. We have like 17 providers here. On a busy day, there's 10. So everybody has at least 5 slots for annual exams.
And
so
you guys are big.
yeah. So we go through a whole bunch of schedules, and then the referrals that we get in from the outside other clinics, like the family health, we get those. So yeah.
Great.
Yep.
Thank you.
You're welcome.
Any questions for Oshana before I move on? St. Thomas More. What can you tell us about improvements? Evie, are you there? Hi.
Yes, this is Evie. Hi. Can you hear me?
I can hear you now, yes.
Okay. Well, we are lucky in the sense that all the Centura clinics and hospitals are connected in the state, so it's so easy for me to track things because I can tell their results immediately when I look from what the hospital has done as far as breast goes. And then I can see on the scheduler just by putting their name in when they've scheduled their follow-up. So then I put that on my calendar so that I get a reminder to check for those results immediately. And if I see on the scheduling side that they have not scheduled their follow-up yet, I'm calling them like Oshana says she does. It is a lot of phone work and a lot of tracking, but it's proven to be working, so I'm going to keep doing that. Even if I have to call them 3 or 4 or 5 times, I still call to make sure they get it on the schedule. Then if they no-show, I can see that too, so I can call them and,
say, hey.
Yeah, so I'm just constantly calling people. I spend a lot of time on the phone, but it does pay off, so I would encourage that for sure.
Okay.
So that covers the completing of breast and cervical outcomes. And then I want to say that the rarely or never screened for cervical cancer and also the women over 50, I think that has a lot to do with new people coming in. We do get a lot of mammograms and budget spending, so to speak, on our follow-ups. But if you're not having new people always coming in to give you these first-time screenings and, to find the ones that haven't had these screenings yet, then that's going to be hard to maintain. So I really appreciate the one-time grant for that. We were able to get a lot of advertising in our little community, and that has helped a lot getting new people into the system.
Great. Yeah, Evie brings up a good point. That the rarely or never screened for cervical cancer, Kristen, correct me when I'm wrong, if I'm wrong, counts each woman only once. It's her first WWC Pap test is when we count women for that indicator. So yeah, the new women coming in, that's who's being assessed or evaluated in that particular indicator or counted. Women 50 and older for receiving mammograms, that's every year. So it's every year, it's all your clients. It's repeat. So.
Oh, okay.
Yeah. So
that's good to know.
There is an indicator that says rarely or never screen for breast cancer. It's just not one of the core indicators. It's just like an extra piece of information because, well, you know how much data you enter into eCaST. It's all there. We can find out anything. But Yeah.
I think that's great. And the advertising is a good example. I'm tying back to those evidence-based interventions of small media and using small media as things like postcards or flyers or maybe local radio or whatever to increase cancer screenings. So I think that's a good example. It's nice to hear sort of how these are coming into play.
Yeah.
And I would point out that this, I'm not sure if Kristen would agree, but I would call the schedule scrubbing a provider reminder system, a type of provider. It's not maybe an automated one, but if you could get it automated, that'd be even better. But part of it is people don't get screening because the provider doesn't realize or can't quickly tell whether or not they've been screened. And so that schedule scrubbing that Oshana and Sunrise talked about is really one of those evidence-based interventions too, about a provider reminder system. So it reminds the providers, oh yes, this person needs a PAP, this person needs a mammogram. Kristen's nodding, so she agrees with it.
Oh, good. Thank you. Are there any questions for Evie at St. Thomas More? Okay, I had one more volunteer to share some success, and that was Tyler County Public Health. Are you there? Star 6.
Okay. Yeah, this is Darlene. She's here.
Hi, Darlene.
Yeah, I'm here. I'm talking about myself in third person. Okay. I'm kind of opposite of everybody else that has talked to a certain extent because we're a small public health department that doesn't do other services, you know, other than women's health and family planning. So all the tools, not all the tools, but some of the tools that the other agencies have said aren't applicable in my case because I can't do in-reach to all the other clients that are there to see, you know, if they need PAPs. Those kind of things. So on the rarely and never screened cervical cancer, I don't know if I've just done that by default. It's partly what she said, the last person said, was that new people coming in has helped with that. Them up.
You're not seeing that, huh?
Well, new people coming in, yes. Here, I'm going to pull up the handset here.
Okay.
Can you hear me better now?
Yeah.
Okay. All right. For the rarely and never screened cervical cancer, I am seeing that. I'm meeting that indicator, but I think it's just because of getting new people in from doing outreach. I have the benefit in this small agency to have a Komen grant, which has helped with outreach even more intensely than the grant that you guys presented out because we have high late-stage diagnosis of breast cancer up here. So this isn't the cervical cancer, but the breast cancer, we're really targeting providers and community resources and that serve underserved people in the community. Also, we have a RICO Health Navigator grant that has been in place for a little over a year now that for Medicaid and Medicaid eligible women, and so we can get lists from them of Medicaid not accessed, like to their PAPs or to their mammograms. They haven't been billing for it, so we can get a list of those kind of people, and so we've been with cold calls on that, which I don't know how effective it is, but it's progressing. At least we're getting the word out and people are hearing that they need to be screened, and so hopefully they'll connect with either their provider. Some of it could be that they'll go to another provider. We're the only one that does it up in Teller County, Women's Health at all in Teller County. Other than some PCPs do basic, but they don't have the grants for it. So anyway, so it is I'm slowly seeing some changes and some more coming in. As far as follow-up, it's the same principles, but I only have to deal with a smaller number of individuals and smaller number of providers. My biggest challenge has always been around cervical because we do not have colposcopy in-house. And they have to go, I say to Kansas, but it's just in Colorado.
Only Colorado Springs.
But it can be a ways. It could be an hour and a half travel for some of the individuals. So that's the challenging. And I do, like others have mentioned, I have direct access to somebody, and I'm calling them and at the facilities that we have contract with, hey, have they scheduled, or are they, what's happening, and getting the reports in a timely manner. And then our health navigator is helping our individuals with some of the more barriers. They get to spend a little bit more time. I was spending time before. It's nice to have somebody else helping with that. Look for those barriers of care. But anyway, we're a lot smaller, so it's different because we don't have these electronic medical records. One of the things that triggered when other people were talking is I do go into one of our main referral sources, Memorial Hospitals or University of Colorado Health, their health link. And so I can see if something's been scheduled or if it's pending still, and that, which I didn't have that access before. So it's nice to be able to follow that way too.
Great. Thank you, Darlene. Okay. Does anyone have any questions for Darlene? Okay. Star 6. Don't be shy.
Should we open it up? Does any other agencies, we asked those agencies to see if they'd be willing to say a few things because we knew they were doing well on their indicators because they had won the quality award. So wondering if anybody else, any other agencies are doing something different that they want to share, or maybe have tried something that didn't work, or maybe want to ask each other about. Maybe, did Kristen, if you want to share something?
I had a question. Several of you have mentioned access to your subcontractors' EMRs. And I was just curious if anybody on the call, either those people or others, had found success or lack of success using CoREO or QHN for that. So I know you have to pay to become a member, for example, of CoREO and be able to get access to Patient 360. And I'm just curious if any of you your organizations have done that, and if you've ever used that for breast or cervical cancer screening, or whether that's not helpful at all for breast and cervical in particular.
Sunrise is getting CoREO, but not everyone has it. Virginia, do you have access to it yet?
No, Samantha was just talking about that. She's working on doing that for us.
Yep. So we don't have access yet, but we will. The feedback I've heard from people who do have access is it doesn't have everything in it.
Right.
So then they end up going back to the either UC Health or McKee banner system anyways. So I don't know. We'll see. I think it is a good idea.
Yeah. I was really curious because I know that it does, there were some startup costs involved in getting that Patient 360 connection, and it dawned on me that maybe that was something that we could potentially facilitate if some of you on the call, and maybe offline, you can also share with us kind of your successes or barriers using it. But I'd love to hear more about if that's been helpful for breast and cervical cancer screening, or whether they're just not being able to provide, as you mentioned, the right amount of data right now.
I know through the one-time funding there was a couple agencies that we did they use their one-time funding for licensing and access to CoRio. And I'm not sure. I can't remember it. I can't actually, but I remember. Put them on the
don't put them on the spot. I know one.
This is Cynthia in Weld, and we were one of those agencies, and we have access to CoRio. And what I have found, even as a provider, is that they're right. They don't have all the information you need, and then you're kind of like asked to break the glass as to why you need further information. And I think for a lot of navigators and even some of the nurses, they don't feel comfortable putting in, that I'm a provider or I'm taking over the care so that they can get to the information they need. So hopefully that'll improve, but that's what we've run into.
So the breaking the glass thing, you're hoping that'll improve in the sense that you'll have a better connections long term between your system and CoRio, so you're not having to break glass, or you're trying to get over the barrier of your patient navigators feeling comfortable breaking glass, which means opening up a patient record without having like a direct connection or the system knowing that it's your patient.
Well, for example, when you, quote, break the glass, you have to put in the reason why, and those reasons are pretty limited, and some of, the navigators don't feel like they can put in, I'm taking over the care for this patient is one of the choices, or, I can't remember, there's 4 different choices, and they really don't fall into any of those 4 choices, so it kind of limits where they feel they can go at this point.
Got it.
Maybe that's something the patient navigation group could
provide clarification on potential.
Or find it helps get CoRio have a reason that provide more to patient navigation.
Yep.
Right.
Yes, please do share. Those sorts of things are extremely helpful, and we'd love to engage in that conversation or help you guys out where possible.
Anybody else want to share things they're doing?
Hi, my name's Kat, and I'm at Weld County as well.
Welcome. You're the new one.
Yeah. I just had a couple of questions in terms of the advertising, what kind of messaging has been put out, and I also was just interested in touching base with external providers and if people have done that and how they've strategized that and engaged with doctors' offices around their areas.
As far as messaging, I think people have done a lot of things, but one of the resources we've directed people is a website called Make It Your Own. It's MIYO Works. So Make It Your Own Works. And you have to log in, but then once you do that, you can make different, basically small media with images and phrases and wording that's been tested for breast and cervical cancer. It also has colorectal and I think HPV vaccine.
They have a ton of different diseases and diagnoses now.
But it lets you add your logo in or a special call Kat at this number. So it has some standard language you can put on, and then it has an area where you can write your own stuff as well. So I know a few agencies use that. And so that's nice to have. It's already, and then it comes in like a PDF that you can just print. So you don't have to figure out what message works.
Okay.
Or you can pick what works for your community better.
Cool.
What was the other question?
About providers.
Oh, one thing I was going to share, I got to sit in on one of our focus groups with non-WWC providers that our evaluator Shannon was doing to kind of learn more about what do other providers know about WWC, and are there any barriers to referring? And one of the things that I think we talked in past things about some of the things they said, but one of the things that really spoke to me is what Sunrise was saying, and I think Peak Vista, that they really want a live person that they can call directly or that their client can call directly to get the client in, that they get, because they feel they want to make sure that this is their patient, that they want to make sure gets that follow-up care just like you do with your patients. And so they want to make sure this client really is going to get in, they're going to get scheduled, they're going to get what they need. And it's hard if they just have to give them a scheduling number, a referral center number or something. They really like that when they know about WWC to be like, hey, Oshana, this is my client, I think she qualifies for WWC, can you make sure she gets in that personal touch they appreciate. So that might be something to offer your providers if you're not hey, here's my direct number, you call me, or just set up what that process looks like when they want to refer someone to you. What does it,
right.
sort of that warm handoff.
Did they give any information about the initial, like having that initial conversation with the providers about, we have this program, it's available? Because sometimes it's really hard to go to a doctor's office and actually speak to, an MD or anything, something like that. It's
I don't
the
know.
reception is there, and that's kind of like, oh, we'll just put it in their mailbox. And I think,
yeah.
Do any other clinics have suggestions for Kat on how to reach out to providers?
How to start that?
This is Evie.
Hi, Evie.
Hi, we did do a mailing to the providers in Fremont County, and we had flyers and a letter of explanation and some cards that they could set in their waiting rooms and an invitation for them to call if they wanted more information or if they'd like a meet and greet type of thing. And out of the 20 we sent out, nobody has called, but we're starting to get referrals from them. So, so now we're going to do that once a year, we decided. So in January we'll do another one, and every January we're just going to remind them that we're here until the grant's gone. So one more time, I guess. But it did work pretty well for us.
Yeah, great.
Yeah.
Thank you.
Evie, if you would be willing to, this is Angie, if you'd be willing to share that letter, maybe we could post something on the blog so that other people could see it, and other agencies too. If you have a letter that works, go ahead and email them to me, and we can post them on the blog to share.
Okay, will do.
Thanks.
Anybody else?
This is Darlene again at Teller County. We have brochures and stuff, but we've had success with connecting with other navigators, so at the different providers' offices. And that could be as simple as it could be not a nurse navigator or an official navigator case manager title. It could be the MA or even the receptionist, to go in and talk with them about these services that are available. And I put together a flow chart of what gaps we can fill for them, say like the underinsured situation where they have a screening mammogram or a Pap test that is abnormal, and then we can do the paying for the diagnostics that are not covered by their insurance or something like that. So I put together kind of a flow chart, but it includes our family planning services too, but I have breast and cervical and family planning services on that flow chart.
Oh, well, I like that. Yeah.
Great.
Thank you.
Great ideas today. Okay, any other questions before we close for the day? Reminder that today is Flora's last day. She's not in the room with us right now. She's tying together some loose ends, but feel free to call Chris or I. If you were assigned to us pre-Flora, you're assigned to us.
Back with us.
You're back with us now again. It's very important to start making sure your eCaST is up to date, because the January bill run is a very, very important date, because we will be looking at reallocations of funds on those days. If you are a care coordination agency and you haven't screened many or any, you might be hearing from Chris and I to see what kind of technical assistance we can provide you if you're missing out on some things. Ms. Kristen Laura?
This is a probably long overdue announcement, but I'm about to have a baby. I'm due January 4th, so if you were wondering who to contact while I'm out, I'll be roughly out January through March. Contact Chris or Ivy if there's any sort of WWC program question, or Marina Milzer if you have budget or spending questions. And as always, if you get confused, I think Ivy and Chris are your best bet for first contact, and they'll figure out who from the WWC team can answer your question.
So use the blog also to start learning how to chat with each other. When you get your email, click into it, and that will allow you the chat function. It'll what is it? It's comments. Comments. Yes. With each other. You know, keep the good conversation of today going.
Share your
blog.
ideas.
And anyone else have anything? Happy holidays. And we're so proud of all the work of all the WWC programs, our clinical services, our care coordination, Wise Woman, and targeted outreach.
They've now all been up and running for a while, so we're finally seeing what is actually happening.
We've often talked about new normals, and I think we are in our normal right now. So thank you, and happy holidays, and we will see you again in February.
Yeah. February. Bye, everyone. What is it? No, don't just hang up. 49.